Good morning. Это я лекцию начну.
Good morning,
Good
doctor.
morning, sir.
Good morning.
Так, with Engels third course start. Today we have lecture. Ну, a lot of students, it's very good. Okay, так. Our lecture today is about... Так, сейчас. About clinical anatomy of the hand, infections on the hand infections. So, the aim of the lecture, to give topographer anatomical basis, to semiotics, clinical course, surgical tactics, and to complications in infections of the hand. The task, classification. Task of the lecture, classification of infections of the hand, anatomotopographic characteristics of infections of the hand, depending on location of processes, ways of pus spreading in infections of the hand, and surgical incisions in purulent infections of the fingers and palm. Number of patients with acute purulent infections of the hand. In polyclinic, it's around 29%. In hospital, 8.6%. Etiology of purulent diseases on the fingers and palm by Chadaev. Different kind of wounds, stab wounds, contused wounds, incised wounds, beating wounds. It's around 52 and 4%. Microtrauma, excoriations and scratch, 11.3%. And 25.8% of patients cannot indicate on damages of dermal integument. Distribution of patients with infections on the hand according to age. As you may see, the biggest parts, 54%, it's around an age of 21, 50 years. So working age, yes, not children's, not older. Then distributions of patients with acute purulent infections of the hand according to the profession. Workers, 49.9%, employers, 20.8%, students, 10.5%, pensioners, 12.2%, others, 5.2%, and inexact information, 1.4%. So workers, around 50%. Frequency of traumas and diseases of parts of the hand. Digitis, 16.3%, metacarpus, 26.5%, wrist and carpus, 6%, and hand as a whole, 6.2%. Classification of diseases of the fingers and hand by Fishman, first part. Fingers, it's a skin. Affected maybe, then inguinal penaries, lymphatic penaries, subcuticular abscess, paronychia, subinguinal, lymphangioitis and lymphadenitis. Subcutaneous head, it's maybe subcutaneous penaries. Tendinous synovial sheath and bursa, it's maybe tendinous penaries. Purulent tendovaginitis of second, third, fourth fingers. Purulent tendovaginitis of first and fifth fingers. Ulnar and radial bursitis. Bones, osteopenaries or osteomyelitis. Joints, articular penaries, septic arthritis, and osteoarticular penaries. And lesion of all tissue of the fingers, it's a pandactylitis. Pundictitis. Classification of diseases of fingers and hand by Fishman second. Hand, it may be skin, subcuticular abscess, corn abscess, subcutaneous fat, subcutaneous palmar abscess, interdigital phlegmon or commissural phlegmon. Then palmar facial spaces. It's a phlegmon of middle palmar space, subaponeurotic and subcutaneous phlegmon. Phlegmon of tenor space, superficial and deep possible, and phlegmon of hypotenor space. Dorsum of the hand, subcutaneous phlegmon is subaponeurotic phlegmon. Then panphlegmon maybe, and arthritis of wrist joint. Classification of anatomical principle on anatomical principle. Panaries, maybe superficial forms, subcuticular panaries or abscess, paronychia, subinguinal panaries, subcutaneous panaries, furuncle or carbuncles of dorsum of the finger. Deep forms, osteal panaries, maybe acute and chronic with fistula formation, tendinous panaries, articular panaries, osteoarticular panaries, pandectolytis. Phlegmons of the hand, it's maybe interdigital commissural phlegmon, phlegmon of tenor space, phlegmon of hypotenor space, phlegmon of middle palms facial space, which divided into subaponeurotic and subtendinal. Then phlegmon of dorsum of the hand, U-shaped phlegmon or crossed phlegmon of the hand with damage of fat spaces according to Pirago-Paron space, and combined phlegmon of the hand. Dates of treatment. Operation is indicated in appearance of persistent pains. Rule of first sleepless night. In the first 24 hours after putting off diagnosis. Terminology. Panaries. Acute purulent inflammation of tissue on the finger. Here demonstrate panaries of the first finger on the foot. Yes, it's on hand. Forms of panaries. It's maybe subcuticular damaged skin, paronychia, infections of the nail hole, subinguinal, infection beneath the nail, subcutaneous, damage of subcutaneous fat, tendinous, tendon sheath infection, osteal, osteomyelitis, articular, septic arthritis, and pandectolytis, damage of all tissues on the finger. Different forms of panaries. So this one, subcuticular, next subcutaneous tissue affected, then tendinous panaries, tendon, here osteal panaries, articular panaries, and so-called collar stud extension. Frequency of different forms of panaries in persons. By different other informations, yes. Well, here you may see that the first place is subcutaneous panaries. Subcutaneous panaries takes first place, more than 50%. It's on the second place, it's a paronychia, 15.6 till 22%. Oriented anatomy of the hand. Skin, yes, dermal, where we have different folds. Then nails, muscular. We may see the tenor, yes, short muscles of the first finger, hypotenor area, short muscles of the fifth finger. Then tendons, tendons on the wrist, we may see the flexor tendons. Then bones, yes, we may palpate them, and vascular. Peculiarity of skin on the palm of fingers and hand. Uh, Stick dense. It is covered by stratified squamous carotid epithelium. It doesn't allow to come out to pass independently. Difficulty to diagnose of clinical signs of inflammation, hyperemia, swelling, edema. Not mobile and good innervated. Good innervated. That's what. Skin on the palm. Subcuticular penis occurs in 10–15% of patients. It is a subepidermal intracutaneous abscess in which the epidermis becomes innervated by a collection of pus within the layers of the skin. These are common on the palmar surface of the fingers and in the fingers webs. 80%. Here, picture demonstrates the area where accumulated the pus. Yes, here you may see first, second finger affected. The indicator showed that the collection of the pus is black. Yes. And how to cut it? We should remove the skin, yes, affected part by scissors. Treatment of subcuticular penis. The raised epidermis may be shaped of richer scalpel. A careful search must be made for any track leading to a deeper abscess, which must be explored and laid open in subcuticular abscess with subcutaneous collar stub extension. Epidermis is excised, convalescent, and shear. Skin of the dorsum of the hand and fingers is thin, mobile, covered by hairs that may be caused of development of furuncles. It is easier to diagnose as clinical signs of inflammation, hyperemia, edema, swelling. Here you may see the Purulent-inflammatory is an infection of the nail fold. On localization of pus, two forms of Purulent-inflammatory are distinguished: superficial subepidermal and deep collection of pus within the layers of the nail fold. Main causes are egg-nail, manicure, prick, ridge. It occurs in the female frequency than in the male in 5 times. Here demonstrates the patient with Purulent-inflammatory. Again, you may see the swelling, edema, red color on the skin, rubor. Treatment of Purulent-inflammatory. Collection of the pus demonstrates, yes. How to treat? We should remove the nail sometimes to do this or evacuate the pus. Subinguinal canaries, primary and secondary, maybe. Cause splinter prick under the margin of the nail, seldom. Contusion, egg and other small traumas. Treatment is trepanation, resection, ablation of the nail. Complications may be in 5% cases is deformated, osteomyelitis and condylomitis. Trepanation of the nail, of course. Subinguinal canaries here. Treats. Surgical tactic in subinguinal canaries. Infection under the three margin of the nail and its distal part. Resection of triangular segment is made. Infection on the base of the nail without detachment of the rest part of the nail. Operation on canavel is made with resection of the proximal part of the nail. And third step is infection on the base of the nail with detachment of the nail, ablation of the nail. We should do. Subcutaneous penis occurs in 50% of patients. In 80–90% of cases, it is located on palmar surface of distal phalanges, first, second, third fingers of right hand. Palm space infections. Here demonstrates accumulation of the pus, yes, and spread of the bone, joint, tendon, or we through the skin of its outside with fistula formation. Here, subcutaneous penis. Subcutaneous abscess of distal phalange. It's the first. Second one, subcutaneous abscess of middle phalange, pus accumulation. Third, subcutaneous abscess of dorsum surface of middle phalange. And here it's so-called subcuticular abscess with subcutaneous collar stud extension. Then here demonstrates the migration. Spreading of the pus on the bone. Very quickly may spread if it's distal phalange, joint, and tendon. And demonstrates the incision, how to do on lateral side. Yes, sometimes from both sides, contraperipherally put, and through it put the drainage. Planning of incisions. Scheme of working surface of the fingers and hand. White color. White color demonstrates the working surface of the hand. The skin creases or flexure lines indicate sites at which the skin is anchored to the deep fascia. Then incisions must be made on the palm or fingers. They are usually designed to follow these lines. Here demonstrates treatment of subcutaneous penis of terminal phalange. Shapes of incisions, different shapes, and demonstrates operation opening of the subcutaneous tissue. It's by hockey stick incision. Incisions due to opening of purulent process on fingers. First, second, and seven. This one is here. Incisions on palmar surface of phalange of fingers. 3 and 9, middle lateral incisions. This and this. Number 4, tear-shaped incision. Number 4 here. Then number 5, hockey stick-shaped incision. This one. 6, pair anterolateral incision. One on the other sides. And number 8, it's a transverse ellipse-shaped incision with dissection of margin of the wounds. Treatment of subcutaneous penuries of middle phalange. Drainage by rubber fenestrated drain in subcutaneous penuries of middle phalange. It's a fenestrated drain demonstrates here. Then introduction of drain into the wounded canal through two contour course. Irrigation of wound through drain and uh, extraction of drain after healing. Complications of subcutaneous infections stem of spreading pus in subcutaneous penuries. Osteopeniris, maybe, then, or osteomyelitis is called then. Articular penuris, septic arthritis, and may spread on the tendon sheath infection, tendinous penuris. Scheme of spreading pus in subcutaneous penuries of proximal phalange. Commercial foramen spreading on the proximal parts of the penis. Osteopeniris, osteomyelitis. It occurs second place after subcutaneous penuris. In 96% of cases is secondary developed. Radiography of the bones. You may see that distal phalange is not detected, yes, is damaged. The infection damaged the bone. And here you may see the drainages. Two drainages or drain the infection space. Osteopeniris of distal phalange of first finger of right hand. Distal phalange is thickened. In wound, extensive necrosis of subcutaneous fat is estimated. It's a drainage of the wound. It is distinguished three types of sequestration: marginal sequestration, subtotal, or total, when it's whole phalange affected. Osteal destruction is exposed on 9-13th days. Osteomyelitis demonstrates, yes, you may see that distal phalange is absent. Radiography of finger in osteopeniris, osteal destruction of distal phalange. Stages of osteal changes in osteopeniris. Appearance of spotted osteoporosis, then periosteal reaction, and destruction of bone. Treatment of osteopeniris demonstrates the spreading from the bone, yes, from joint, nail, side, subcutaneous tissue. Well, We should do hockey stick incision. Affected part should resect, if it's possible. If it's distal, yes. If it's, for example, in middle of the ball, you should resect this part. Here, half of pelvis resected. If it's with joint, we should resect end joint, as here demonstrates. Treatment of osteoporosis. Hockey stick shape excess, demonstrates here. Necrotomy, sequestrectomy. It's when we remove the affected part of tissue and bones, sequestrectomy. And drainage of wound. Drainage. Again demonstrates the situation, osteoporosis. Good opening, yes, you may see the pelvis here. Necrectomy and foot drainage. Attention, you must note. Pairs double side accesses on the terminal pelvis. To carry out amputations of fingers. It demonstrates here. This incision you should do. Articular and osteoarticular pelvis. It takes 2 and 3 till 5 and 8%. Restoration of function of joints is possible in series, so 10-20%. In subtotal and total damage of articular ends of the bones, function is impossible. Here demonstrates articular pelvis opening. Then we put the immobilization. Immobilization to prevent the motions on the affected joint. Stages of articular pelvis. Serous inflammation, purulent inflammation, osteoarthritis with damaged articular ends. Structures which are involved in processes in articular pelvis. Bone or joining ends, ligaments, and capsule of joint. Articular pelvis demonstrates infection may spread from bone, from the skin, subcutaneous tissue. It's a puncture demonstrates here of the joint. Then, if affected both ends of articular joint, we should resect them. All joint with resection of distal and proximal parts. Here some demonstrates. Clinical presentation. This patient. Pains in region of joint in movement, then in rest. Thickening of the finger in regional joint. Finger has spindle-shaped form. Local tenderness in axial load. Tenderness in appearance muff. Formation of fistula doesn't lead to convalescent. Treatment of articular pelvis septic arthritis. Diagnosis is indication for urgent operation. Puncture of joint in serous early stage 1. Arthrotomy without damage of flexor tendons and microtomy. Drainage of joint, immobilization. Osteoarticular pelvis, heart affected. Some situation, immobilization of the finger in physiological position, flexion position of first finger. Yes. Use of destructive apparatus in complex treatment of articular pelvis. Here demonstrates different types for immobilization. Metallus reconstruction outside immobilization. Tendinous penis tendinogenitis. Damage of synovial sheath and tendons of flexor and damage of ulnar and radial bursa in tendinogenitis of first and fifth finger. You remember from our process that first connected with radial bursa and fifth connected with ulnar bursa. Signs of tendinogenitis. Even swelling of the finger with spreading of edema on dorsum of the hand. Passive movements cause severe pain. Tenderness in the region, blind and cul-de-sac. Passive extension of the proximal joint causes pain. Troubling pain and swelling of the finger, which takes up a slightly flexed position. Structure of synovial sheath of the flexor tendon. Deep flexor tendon here. It's a superficial which divides into two. In classes we showed you, yes, around tendon, synovial sheath, synovial vagina. Around vagina we have fibrous sheath. And from lateral vessels to tendon comes blood supply. Yes, it's so-called mesotendon, mesotendon here. Mechanism of ischemia in the flexor tendon. The pus accumulated in synovial vagina extend and press the mesotenome. If mesotenome compressed, blood and nerve supply prevents. That's all necrosis of the tendon. Tendinous penis tendinogenitis. Here demonstrates tendinous penis for finger with necrosis of flexor tendon on ulnar surface of finger. Purulent fistula is located. It's a fistula of the skin. Tendinous penis of tendinogenitis. Here, tendinous penis of fifth finger of left hand, indicated by ulnar tendinobursitis, infection spreads, and phlegmon of fat space according to our forum. Treatment of tendinogenitis. This patient demonstrates, yes, we should open hand on finger and part where situated the bursa and drainage the Pyragov space. It's a drainage. Again, treatment of tendinogenitis demonstrates good deep opening, nephrectomy, drainages, primary opening of tendinogenitis in 26 and 3% treatment date, carrying out operation in the presence of purulent wounds after making operations, 57 and 9%, and treatment in partial or total destruction of the flexor tendon, it's 15 and 8%. Incisions in tendinogenitis and tendinobursitis. Incisions by Biru, second finger, then by club, double-side incisions. Here demonstrate incisions by vertical. In this picture by Fishman. here by Zaitsev, and canal incision here. In this picture, opening of tender bursitis here by Fishman, here by canal. Endoscopic release for carpal tunnel syndrome demonstrates in this picture. It is necessary during operation to elucidate the ability of the tendon to determine leakage of pus in head of the hand and fingers, how is synovial sheath and leakage drained, to determine volume of necrotomy of the tendon. U-shaped phlegmon on the hand, damage of ulna and radial bursa, damage of synovial sheaths of the little and thumb fingers. You remember that U-shaped phlegmon possible if it's affected fifth or finger because they have community with bursas. Fifth has community with ulnar bursa, first radial bursa, and sometimes between ulnar and radial bursa may be communication. An infection may spread from one to another and form so-called U-shaped phlegmon, Latin letter U. Complications in tendinogenitis. Phlegmons of middle palmar space, tenor space, and hypotenor space. Phlegmon of Pyragos head space. Articular penis, septic arthritis. Formation of fistula. Contractures after dissection of tendon. Conductivitis. This is damage of all tissues of the finger. Here demonstrates conductivitis, yes. And skin, subcutaneous tissue, tendon, and bone. All layers affected. Here demonstrates the patient with conductivitis or distal part of the tongue. Again, conductivitis. Treatment of conductivitis. Good opening should be. All tissues is necrectomy and drainages. Conductivitis of first finger of right hand demonstrates here. On operation, destruction of bone of proximal phalange and metacarpophalangeal joint. Necrosis of soft tissues and are defined. You may see affected part here on the bone. Necrosis everywhere. Scamal zone of maximal tenderness in different forms of penis. Ostial, penis, articular, subcutaneous, tendinous, tendinous penis of fifth finger and ulnar tendinobursitis, and tendinous penis of first finger and radial tendinobursitis. Rational incisions in penis. Letter A, in articular and osteoarticular penis. Yes. Then B, hockey stick shaped incision. Letter V, in localization of focus on middle and proximal phalanges. Yes. And letter G, in tendinous penis of fourth finger. Subcutaneous purulent-inflammatory process is called abscess. Abscess is a limited collection of pus in tissue or organs. Lobular or cellular structure of subcutaneous fat of the palm demonstrates here. Septus, which connect skin to aponeurosis. Yes, and this septus divides subcutaneous tissue into lobes, segments. If here will accumulated infection, it will be abscess, local inflammation. Subcuticle abscess or corn abscess. Here demonstrates corn abscess. You may see how it may spread. And treatment checked by scissors or incisions. Cholesterol foramen area. Palmar corn abscess. This one. Interdigital phlegmon. Cholesterol phlegmon. Here, phlegmon of tenor space. Phlegmon of middle palmar facial space. And phlegmon of hypotenor space. Phlegmon is acute diffuse inflammation of the thread. Subcutaneous, intramuscular, interfacial, maybe, characterizing by tendency to spreading, because it's not limited. Interdigital phlegmon, menstrual phlegmon, demonstrates here where it may spread, yes, into another menstrual spaces, the tendinous space, subcutaneous space, it may spread, subaponeurotic space, spaces between the fingers, synovial vaginas of the fingers, flexors of course, and subcutaneous tissue of the fingers. Then it may spread on the dorsum, of the hand through the vermiform muscles. Interdigital phlegmon, commissural phlegmon, opening of drainage of commissural phlegmon. As you may see, it goes through all tissue of the hand, from palm to the dorsum, and good drainage or contrapectoral. Fat spaces on the hand. Here demonstrates subaponeurotic fat space between aponeurosis and tendons, flexor tendons. Here demonstrates subtendinous under the tendons and incisions, by which possible to drain these spaces. Fat spaces on the hand. Dorsum of the hand, we have subcutaneous subaponeurotic fat and subaponeurotic. Supra first. The supraaponeurotic and second one subaponeurotic fat. Middle fat space, subaponeurotic slit and subtendinous slit, which communicated with the forearm. Lateral fat space, internal space, maybe superficial and deep slit affected, and medial fat spacing, hypotenor space. Classification of phlegmon on the hand. Interdigital phlegmon or commissural, phlegmon of the tenor space, superficial, phlegmon of the hypotenor space, phlegmon of the middle palmar space, maybe superficial subaponeurotic and deep subtendinous, phlegmon of the dorsum of the hand, U-shaped phlegmon, and common phlegmon of the hand. Common principles of the treatment. Treatment in hospital. Rest in the position of immobilization. Elevation or to minimize edema. Appropriate antibiotic treatment. Surgical drainage of localized pus. Rehabilitation, then the infection is under control. Phlegmon of Tamar space. You may see swelling, red color. It's incisions on palm surface and the dorsal. Deep phlegmon on the Tamar space. Okay, here under the short muscles of the first finger. And incision goes in the fold between first and second fingers. Or it's maybe here on palm and on dorsal on both sides. Scheme of incisions and drainage of phlegmon of Tamar. Here demonstrates it's a drainages. You will see they enter from palm and exit from dorsal. Incisions. Scheme of drainages putting, crossing drainages. Hypotenor space here. Incision on palm surface, dorsal surface, and again crossing drainages. Phlegmons of middle palmar space. Here is situated peripheral subacroneuritic. Here demonstrates deep or subtendinous. And incisions by which possible to drain these spaces. Drainage of phlegmons of middle palmar facial space. Dangerous zone of the hand, you remember canal dangerous zone where we have the division of the medial nerve into main branches which supply the muscles of the first finger and the other. Well, here impossible in this zone, impossible to do incisions. Yes, and it's an area where we do incisions and put drainages. Incisions and phlegmons of middle palmar facial space. So it's a projection of middle palmar space. Then this first, it's an incision by Isolan, and second, incision by Pico. Here demonstrates canaveral incision. Canaveral incision, S shape. Rational incisions in phlegmons of the hand. Palmar cornux S, interdigital phlegmon, mesural phlegmon, then phlegmon of Tamar space, here, phlegmon of middle palm, facial space, and phlegmon of hypotenor space. Phlegmon of the dorsum of the hand, primary and secondary, subcutaneous and subfacial. Edema, ruler, and drainages. Which types of incisions possible to do, and how to put drainages, forcing drainages for irrigation of the space. Phlegmon on the dorsum of the hand, subfacial or subopeneurotic. Here subopeneurotic space on the dorsum. And incisions. Here demonstrates in frontal plane. Yes, it's incisions which demonstrates in horizontal plane to open the subopeneurotic space. So, boys and girls, our lecture is finished. Well, actually, this topic you had in flexible classes, yes? No, lecture we common demonstrates different surgical tactics, yes, and different types of inflammations. Well, no, that's all. If you have no questions.
Okay, thank you, sir.
До свидания.
Спасибо, сэр.
До свидания.
Thank you,
Да.
doctor. До
До свидания,
свидания.
сэр.
Bye.
Thank you, sir. До свидания.